Ventilator-associated pneumonia is one of the common cause of increased morbidity and mortality in a patient admitted in ICU on mechanical ventilation. We should practice all the measures which increases the incidence of VAP in ICU. And if ventilator-associated pneumonia or VAP develops in ICU, we need to diagnose it as quickly as possible and start the management to improve the outcome in the patient and to reduce the morbidity and mortality. In this topic, we would discuss everything about which we need to know about VAP, right from its definition, how do we define it, what is the incidence, what is the risk factors which increases the incidence of VAP, then what is the pathophysiology of VAP, then what are the VAP prevention bundles, how do we develop the clinical practice to decrease the incidence of VAP in our ICU, what are the clinical features, how do we diagnose it, what is the management, everything we will discuss. So let us start our discussion right from definition of VAP. So how is VAP defined? VAP is a type of hospital-acquired pneumonia which is defined when it appears in a patient on mechanical ventilation after 48 hours. So a patient on mechanical ventilation for more than 48 hours, if a pneumonia appears, that is called VAP. So VAP is defined as a type of hospital-acquired pneumonia that develops after more than 48 hours of mechanical ventilation. So remember, the timeline is 48 hours. So if a patient is for more than 2 days on ventilator and then develops pneumonia, it's called VAP. If it is less than 48 hours, then it is called hospital-acquired pneumonia, right? Okay, so what is the incidence of VAP? The International Nosocomial Infection Control Consortium, they report that the incidence of VAP is 13.6 per 1000 ventilator days, right? So it is 13.6 per 1000 ventilator days. So overall rate, right, is 13.6 per 1000 ventilator days. Now the incidence of VAP varies according to the patient group, according to the risk factors associated, and according to the hospital setup. So incidence varies according to, number one, the patient group. So it would be more seen in higher age group of patient according to the risk factors and definitely according to the hospital setting. So it also depends a lot on the hospital setting. Okay, what are the practices overall there, right? Now average time to develop VAP is found to be 5 days after initiation of mechanical ventilation. So average time taken to develop VAP is 5 to 7 days after ventilation started, after start of ventilation, right? And mortality is found to be 24 to 76%. So mortality is in different setting 24 to 76%. Patient in high risk group, we have a high mortality, right, varying from 24 to 76%. Now what are the risk factors which increases the incidence of VAP? There are some risk factors which can be modified by our clinical practice and we can decrease the incidence of VAP by by modifying those factors, and there are some non-modifiable factors which we just need to know that this is a patient in whom there is a high risk of developing VAP. So before talking about the risk factors, let us see how does the VAP develops. What is the pathophysiology of VAP? Now, VAP is developing because of the endotracheal tube and the tracheostomy tube which we are using for mechanical ventilation. Now, presence of this ET tube and tracheostomy tube disturbs the anatomy and the physiology of the airway, particularly the functional mechanism of clearing the secretion. So, what happens that the secretions, they accumulate in the oropharynx. These patients, they're unable to clear their secretions. So, the secretions accumulate in the oropharynx and this leads to micro and macro aspiration. Apart from that, over the cuff of the ET tube or tracheostomy tube, the secretion accumulates and which causes the growth of the bacterial flora, and this bacterial flora forms a antibiotic resistant biofilm. This slowly goes to the lower respiratory tract, and in patient with less immunity, patient with high risk factors, all this leads to development of pneumonia, right? So the pathophysiology is mostly because of the presence of endotracheal tube or the tracheostomy tube. What they do? They affect the anatomy and physiology of the anatomy and physiology of upper airway. Anatomy and physiology of airway, especially the functional mechanism to clear the secretion. So, functional mechanism to clear secretion, right? Now, in intubated patient, apart from the disturbance of anatomy and physiology, they have a decreased consciousness and they have inability to clear the secretion. So, decreased consciousness and inability to clear secretion. So, all this would lead to pull up of secretion in the oral cavity. So, this will lead to pooling up of secretions, right, in oral cavity, in oropharynx, and this leads to micro and macro aspiration. So this would lead to micro and macro aspiration, one of the major cause of VAP. Okay, now the flora of the normal oral flora, this normal oral flora, they start to proliferate around the endotracheal tube cuff. They start to proliferate around endotracheal tube, and they build up a antibiotic resistant biofilm. Antibiotic resistant biofilm. So they develop a antibiotic resistant biofilm. This antibiotic resistant biofilm, right, which is developed slowly, this goes into the lower airway, and patient with reduced immune response, all this causes the pneumonia to develop, right? So this is how the ventilator associated pneumonia develops. Now in these patients, if there is more of the risk factors, the chances of developing the ventilator associated pneumonia would be more. What are the risk factors? Now, what are the risk factors which increase the incidence of VAP, As I told you, some of the risk factors can be modified, and we call it modifiable, and if we modify them, then the incidence of VAP will decrease. And some are non-modifiable, which we need to identify the patient with high risk of developing VAP. So let us see the risk factors. Risk factors like increasing age, which is definitely the non-modifiable, then chronic lung disease, non-modifiable, then your micro and macro aspiration. By taking some measures, we can modify it. Then chest and upper abdominal surgery, non-modifiable. Then previous antibiotic therapy, non-modifiable. Reintubation, this is a modifiable risk factor. We need to plan properly to prevent any reintubation to happen in these patients, which increases the incidence of VAP. Then acute respiratory distress syndrome, previously non-modifiable. Frequent ventilator changes. We should not practice circuit and frequent ventilator changes, which is a modifiable risk factor. Then polytrauma, this is non-modifiable, and prolonged paralysis. Prolonged paralysis we can avoid. We should avoid paralysis and heavy sedation in patient and should give daily sedation break to decrease the incidence of VAP. So this is modifiable. Apart from this, presence of comorbid condition. Presence of comorbid conditions like diabetes, right, like immune disease, immuno, immunological diseases, all this, or cardiac disease or renal disease, all this would increase the incidence of VAP. So this is again a non-modifiable factor. So we need to identify the modifiable factor and we need to modify it to reduce the incidence of VAP, and we need to identify the non-modifiable factor and we need to identify the patient with high risk of VAP to manage them. Remember, if the VAP is developing in less than 4 days, if it is developing less than 4 days of mechanical ventilation, we call it early onset. Early onset and early onset VAP, they have a better prognosis, no morbidity, and they respond to antibiotic well. But if it is developing after more than 5 days of mechanical ventilation, then mostly it is multi-drug resistant microorganism which is causing it. So this has increased morbidity and mortality, right? So late VAP, they have increased morbidity and mortality. Now let us talk about the risk factors of the MDR developing VAP, right? So more than 5 days, there is an increased risk of multi-drug resistant microorganism causing the pneumonia. So what are the important risk factors which we should consider? Now, for any MDR resistant VAP development, there are some common risk factors. That is IV antibiotic use in previous 90 days, septic shock at the time of VAP, ARDS preceding VAP, more than 5 days of hospitalization prior to the occurrence of VAP, and acute renal replacement therapy prior to the VAP onset. So all this increases the risk of MDR pathogen. MDR pathogen. In MDR pathogen, Pseudomonas resistant we need to identify, and MRSA, that is methicillin resistant staphylococcus infection, we need to identify. So for MDR, Pseudomonas and other gram-negative bacilli, if in the ICU where the patient has developed or patient is admitted, if more than 10% of the pathogen are the gram-negative isolates resistant to the antibiotic considered for monotherapy, then there is a high chance that MDR resistant VAP would develop. Then in treatment in ICU with local antimicrobial susceptibility not known, and colonization in patient, if previously a MDR pathogen, Pseudomonas, MDR, the multi-drug resistant Pseudomonas and gram-negative pathogen was isolated, again they are at a high risk of developing that pathogen. So these are the conditions which would develop MDR, Pseudomonas infection risk factors. Then MDR, MRSA, same. If in the ICU more than 10% of the isolated pathogen are MRSA, then again the risk of MRSA increases. Patient in whom MRSA was previously isolated, again the risk of MRSA is more. And in ICUs where they don't know the prevalence of MRSA, then risk of MRSA we consider is higher. So we need to consider all these factors when we are choosing the antibiotic, which we will discuss later on also, right? So these are the risk factors for developing multi-drug resistant VAP, okay? Okay, now let us talk about prevention, very important. VAP is associated with high morbidity and mortality. And as we discussed, the risk factors, there are some risk factors which are modifiable. If we modify those risk factors, the incidence would decrease. The training of the nursing staff to practice the VAP prevention bundle and regular follow-up of the practices and regular antibiogram to see whether the antibiotic resistant is developing or not, all this would help in decreasing the incidence of VAP. Unprecedented or unwanted use of antibiotics should be avoided. So to prevent VAP, the VAP, that is ventilator-associated pneumonia, prevention bundles should be developed. The nursing staff should be trained to practice these bundle, and regular follow-up of all the practices should be seen, and unwanted uses of antibiotics should be decreased. So unwanted use of antibiotic should be decreased, right? Because this all increases the incidence of VAP and increases the incidence of multi-drug resistant pathogen causing VAP. So we need to practice. There are some measures in ICU which should be taken to prevent VAP, and there are some measures which can be taken to prevent VAP. So let us discuss it in two categories. Some measures which we should take to prevent VAP. Now, VAP is developing when we discuss the pathophysiology. It is developing because of your presence of ET tube and tracheostomy tube. This is disturbing the normal anatomy and physiology and clearance of the secretion ability of the patient. If possible, don't use these devices. That is, if possible, to intubate, to ventilate via non-invasive method. If possible, to manage the patient on non-invasive ventilation or HFNC, we should always try it. In the topic non-invasive ventilation, I talked about that every patient who does not have the contraindication of NIV should be given a trial of NIV prior to invasive ventilation, because this would decrease the incidence of nosocomial pneumonia. So, first thing which we should practice is use high flow nasal oxygen or NIV when appropriate to avoid intubation. Facilitate extubation as soon as possible and prevent the reintubation in patients by taking a proper protocol, following a proper protocol. Then, provide enteral instead of parenteral nutrition when possible. Enteral feed has shown to decrease the incidence of nosocomial pneumonia, right? So enteral feed should be promoted. Parenteral nutrition has its own complication associated. Then avoid the changing of the ventilator circuit. Very often changing of the ventilator circuit without any reason should be avoided. It should be changed only when there is a visual soiling of the circuit, secretions, etc. in the circuit. Then if the circuit is malfunctioning or if the manufacturer recommended days of changing the circuit has come, right? So it should be changed only if it is visibly soiled, if it is malfunctioning, or fixed number of days by the manufacturer recommended to change the circuit. Then we should minimize the sedation. Every day sedation break should be given. Maintain and improve the physical conditioning by active and passive exercise, right? Patient should be kept active. Provide oral care without chlorhexidine. Good oral hygiene is key to prevent VAP. And latest, should be done without chlorhexidine. Chlorhexidine has shown to increase the mortality, the reason unknown. So chlorhexidine nowadays is not recommended. Then set the head of the patient in the bed at elevated 30 to 45 degree, right? This would decrease the risk of micro and macro aspiration. So we should keep the bed of the ICU bed of the patient elevated to decrease the incidence of micro and macro aspiration. So these are the essential practice which should be practiced. Then there are some additional practice which can be considered. Now, tracheostomy after 1 to 2 days, if it is expected, 1 to 2 weeks, if it is expected that mechanical ventilation is going to continue. Tracheostomy causes a better pulmonary toileting. So this will decrease the incidence of VAP. If patient is on endotracheal tube on mechanical ventilation and it is expected that it will go on for more than 48 to 72 hours, then special tube with subglottic secretion drainage ports should be used. So if we see, this is a special tube with a subglottic drainage port. So here the secretions which gets accumulated just above the cuff, this can be drained by this subglottic drainage port. So if we are expecting for more than 48 to 72 hours, patient will be on mechanical ventilation, this tube can be considered, though definitely economics we need to consider, it's a costly tube compared to normal tube. Post-pyloric feeding in patient with high risk of aspiration and use of selective oral or digestive decontamination in ICU. So selective oral decontamination and selective digestive decontamination should be selected for those ICU where there is low antibiotic use and less risk of multi-drug resistant microorganism, because use of selective oral decontamination and selective digestive decontamination has shown to increase the antibiotic resistant in those ICU where there is a high use of antibiotics. So it is a guarded practice which should be done at some centers only, then only it will have a positive result. So these are additional practice. Every hospital should develop their own VAP prevention bundle. Now let us discuss few important, let's say, factors which we should consider in developing VAP prevention bundle. Now, one of the